Hello, my name is Jane O'Rourke. I'm a child, adolescent and family psychotherapist. And I'm gathering with me today two experts in trauma, Jo Stubley, who leads the trauma unit at the Tavistock Clinic, and Graham Music, who's a consultant child, adolescent and also adult psychotherapist as well. And the reason why we're coming together is that we've been very aware of the amount of trauma that our NHS colleagues and other health workers and public sector workers are experiencing, a huge amount of trauma. And we're thinking today about what we can do about that. Why is there so much trauma? And what measures can organisations put in place to try and lessen the trauma? And also, what can individuals do to try and lessen that impact too? So welcome, Jo, welcome, Graham. I hope I've introduced you okay. Is there anything else that you'd want to add to what you do that might inform our discussion today? I know, Graham, that you've worked a lot with traumatised children and also with adults as well. And Jo, you've led the trauma unit for some time. You've been very innovative in introducing an awful lot of techniques beyond psychoanalytic psychotherapy, such as EMDR, yoga for trauma, which is what I do with you in your department. If there's anything else to add, then please say. Otherwise, I'm interested in why you think, Graham, that there's an awful lot of trauma around at the moment that being experienced by healthcare workers in the NHS and in other professions.
Well, so it depends how we think about trauma, but I would see trauma as something which is overwhelming to our usual ways of coping and managing. So what's traumatic for one person won't necessarily be traumatic for another person. So the historical kind of medical definition, I think, Jo might correct me because she's the doctor and psychiatrist as well as psychoanalyst, etc., is it's a kind of piercing of the skin. And I tend to see it as a piercing of the psychic skin in a way. And a bit of piercing of skin is not a disaster. We need it sometimes. It's a bit what we call a hermetic response. You need a little bit of stress in order to be challenged, in order to grow and develop, what they call a hormetic response, a bit like going to the gym. But when it becomes overwhelming, then, well, that's what it literally means. It's overwhelming, it's too much to handle. And then all kinds of strategies come into place to try to help cope with that uncopable with thing. And in the current crisis, I think, there's a whole range of different traumas, and some will be experienced more dramatically than others. So if people have a history of trauma, for example, then they're going to experience the same thing as the person next to them who hasn't had a history of trauma much more dramatically, and it might trigger them into all kinds of traumatic states, post-traumatic states, etc., dissociative states. So it's partly to do with a person's individual resilience, I suppose, and previous experiences, but also a lot depends on the context within which we're experiencing something. So if we're working in, I don't know, a hospital unit like ICU or an acute assessment unit, or a supermarket, a lot depends on what kind of support structures and systems are around you, how much sympathy and compassion there is for what's going on, how much there's a culture in which difficult thoughts and feelings and worries can be tolerated, or do things have to be brushed under the carpet? If somebody looks like they're being ill, are they told they can't say anything? I know that we had an example like that recently where somebody was told they're not to tell any of their colleagues that they were ill, which was pretty shocking. And if you're working, for example, in an ICU, then it's a traumatizing place anyway. You're working with trauma day in, day out. And often there was overwhelm in those units even before COVID came along. And since COVID, there's such profound amounts of overload and staff shortage and working without PPE and all those things. You really, really need a sympathetic culture in which difficult thoughts and feelings can be tolerated, reflected upon, given space, and not kind of manic, just get on with it and don't complain type of culture.
So, Jo, I'm interested in what you've called the paradox of the COVID-19 pandemic. You wrote about this, that there's a particular there's particular aspects of this pandemic which has made it very traumatizing for healthcare workers and other people in the front line.
Yeah, I think it really draws on attachment theory, this idea, and I think it's a really straightforward and helpful one, I hope, for thinking about the impact. When any of us are under threat, our fear system gets activated, and one inbuilt way of trying to feel less threatened and less fearful is to turn towards our attachment figures, the people who make us feel safe. And the difficulty at the moment is that we are having our fear system activated continuously by the threat of COVID-19, this invisible, potentially deadly virus that any of us could get. And that inevitably requires us then to find some way to feel safe again, to be able to keep going in our lives. And we want then to turn to people, and often that is a very physical turning to. I think many people have spoken about how much they miss the hugs from their loved ones that they're not able to see because of the lockdown. And that paradox of wanting to turn to the ones who make us feel safe and to get that physical reassurance is precisely the thing that because of COVID-19 we can't. And that, I think, also then engenders something of what Graham was touching on in relation to trauma, the sense of helplessness, that how we would normally respond by making ourselves feel better through going to what feels safe is not possible, and the feeling of being helpless and overwhelmed is more likely to occur.
Mm. Yeah, and that Bessel van der Kolk wrote about that there's preconditions for trauma, and one of them is helplessness, and that feeling of being trapped as well, which I think a lot of frontline workers have felt that, haven't they? That they've felt this duty to go into work even though there's a risk to themselves and to their loved ones, but they feel that they have to do that for their colleagues as well as their patients and the other people that they're looking after. And I think they feel that they can't sort of manage this very well, and they feel trapped by it. And that is really very difficult in terms of trauma, isn't it?
Absolutely. And I think that there is something about having to acknowledge the resilience of frontline staff, that a lot of what they do ordinarily is what would, to the general population, potentially look very traumatic. And yet there is the reality that with COVID-19, there have been a number of factors that might make it more likely for frontline staff to get traumatised. And you were just touching on one of them, but I was also thinking about the breakdown of the usual structures that has occurred. Even if we think, for instance, about the number of new teams that have had to form, people that have had to come together quickly, people being redeployed. I think that those issues around the fact that many of the ways in which normal structures are put in place within our institutions that help us manage anxieties have been shaken by COVID-19. So it means that I think the difficulty of managing the anxieties has increased, and the sense that something that is out of their control, that doesn't normally kind of occur to them. And interestingly, I don't think it's just about the lack of PPE that's been problematic. I also think the use of PPE has been problematic. The fact that we have been divided, as you know, when one is on front line, from actually being able to talk to people in a face-to-face way, an advisor in front of them. So the potential for that connection, which again comes back to that sort of attachment idea of needing to connect, has also been impacted upon by having the PPE there.
Yeah,
I'm agreeing with that, Graham.
Yeah, absolutely. And I think there's something obvious. I think Jo put beautifully the importance of what we get from an attachment figure who gives us a sense of safeness or safety from danger. And of course, one of the things you get from that is you get a release of things like oxytocin, which lowers social fear, allows you to breathe more deeply, allows you to interact with other people more. And those are all the things that we're losing. And of course, there's a few very interesting things, for example, about PP, which I absolutely agree with. So for example, those muscles around the eye, which are so expressive, Stephen Porges talks about ubiquitous ocularity, or whatever they're called, absolutely crucial for communicating emotional states. And if those things are covered up, and if you don't have touch, which lowers social fear and releases, induces oxytocin release, etc., and you don't have physical proximity and there's wariness, then all of these things make a challenging situation much more likely to become a traumatic one. But I think it's much more about, rather than technical things like that, it's much more about a culture in which it's possible to think about these things. I think, for example, in a hospital or even in a supermarket, or I think it's things like having a handover, which isn't just you've got to do this, this, and this, and this isn't done, but actually, how's it been? How are you feeling? What's been going on? How is it like? Even a moment when somebody died, I found working in a hospital where we're doing an intervention for a very stressed unit, that if somebody died, they would immediately take the body out, change the bed, but there wasn't a second to appreciate that something very, very important, really profoundly important, had just happened, and just take a breath. And I think a lot of that is because of the fear of the feelings that might come up if you stop and think. And so in psychoanalysis, we often, of course, think about manic defenses and defenses against anxiety within institutions. And there's a bit of an idea that if we stop and allow a feeling, it will overwhelm us. And my experience is that that's not the case. That leaving a bit of space for feelings, leaving a bit of space to process what goes on, will allow you to go forward feeling stronger, more able to cope, rather than just driving through it in a slightly manic, overdetermined way.
I mean, what's striking me about this pandemic is that healthcare workers are having to do things that family members would ordinarily do for dying patients. They're the people to hold their hand. I've got a friend who's a nurse, and she's, it's been really traumatic for her. She's having to FaceTime relatives who haven't seen their loved ones, sometimes for weeks, and pass on, the loving wishes of a granddaughter or a daughter or a wife or husband. And I'm wondering how, this is for you, Jo, really, because you're a doctor, you've been in you trained as a physician first before going into psychiatry. How well equipped are NHS workers and other healthcare workers to do this job of being an emotional conduit and supporting patients and families through these really, really difficult situations?
I think it's a really good question, and I was thinking about this in relation to my own training and experience. When I qualified, I worked in intensive care, in accident and emergency, and on oncology wards, and some time ago now. And my experience then was of a system that defended itself, first of all, by having very clear hierarchies. So you knew who was in charge, and that works in terms of making sure that things are safe and they get done. But part of those hierarchies mean that it can be very difficult to show vulnerability within the context of the hierarchy. I think the other thing is that it is designed in a way that particularly medical staff within the hierarchy, and the further up you get, they hold authority. So the potential of being able to be collaborative and to have a kind of mutuality in things can be discouraged in that context. Now, of course, those things are really helpful when you need someone to be making really difficult decisions quickly. But that can feel, particularly if it becomes more rigid, something that then the sorts of things that you were just talking about, Graham, are really difficult for people to do. How do you stop and think and allow those feelings to be acknowledged if you've got a system in which you have got to keep things, absolutely in this, action kind of scenario? And I think the difficulty, particularly about COVID, is that it's already raised the frontline staff, states internally in terms of what we've been talking about, their own helplessness, their own sense of being trapped. And I would also add the helplessness, I think, in relation to not having a specific treatment for COVID. You know, a lot of the way that the medical system works is that we know what to do and we know how to do it. And in general, that's, you know, being able to then have a clear rationale for why we're doing it. Whereas people here have been struggling. They don't know. They're doing things because, you know, there's no evidence, but there's an idea that this might be helpful. And that really challenges this authoritative, I know how to manage this kind of idea. I also think that there's been something, as we said earlier, about the redeployment and the long hours that have stretched people enormously. And again, I think have possibly pushed them more into these rigid ways of working. And so that struggle to just be able to get enough sleep and to eat sufficiently and to be able to have that good contact with others, when the good contact with others also might raise the anxiety and guilt of, am I bringing the virus home? That becomes even more problematic. So they've got an awful lot on their plates whilst trying to sit between these two different cultures of the action that's required and what we're talking about, which I think is kind of under the heading of self-care, of taking that time to stop and just check in with what you are actually feeling when you're feeling perhaps very full.
Yeah, and I really value that, Jo, in terms of my own work when I'm working with patients who are really traumatized. The value for me in being able to recognize what's going on for me and being able to take care of myself in order to be able to then take care of that person. And I think that's really what is one of the biggest differences, I think, from what I can see on the front line for frontline staff, is that they're very much being encouraged to think entirely of the patient. You know, but it's that oxygen mask analogy, isn't it? That, you know, they say to parents on a plane, you know, give yourself oxygen first in order to be able to help your child if in the event of an emergency. But these are emergency times, and I think there is a sort of a tendency in emergencies, isn't there, to sort of just go, just do whatever we can. But I think not even being able to recognise what's going on for ourselves, I think this is really what's risking trauma settling in for that person. When a person's just died or they've had to just deliver some really difficult news, and to not be able to reflect how that is impacting on you, I think it's potentially very dangerous. And you're very good on Graham on the sort of the physical impact of what trauma does to bodies. Could you tell us a little bit more about what happens when somebody has an unprocessed trauma? What happens to them physically and in terms of their outcome?
Well, everybody's response to trauma will be slightly different, but there's a few classic things that Jo already hinted at. So an initial response to something traumatizing should be a kind of should be a way of coping which puts you into the kind of the classic things people talk about, fight or flight, where you're muscular tension and you're ready and you're prepared. And I think that could often give rise to kind of bashing away a bit too much, and that has a long-term cost. In a very, very simple way, it has a long-term cost on you. So, for example, one of the neurochemicals that gets released is cortisol. Cortisol is a steroid that lowers your immune system. So inevitably, it will have a long-term effect on practitioners' health. And if that...
And probably more likely that they're going to perhaps be susceptible to COVID as well.
Exactly, and just about everything going. And you know, our bodies aren't designed, like every mammal, our bodies aren't designed to be constantly on alert to very serious danger. And you know, we're expected to face a danger and then calm down quite quickly. And if we're a kind of a deer or something, and then start eating grass in the next field within 10 minutes. But if you're constantly barraged by traumatic experiences, then you don't have the chance to recover. So the system called the healthy branch of the parasympathetic nervous system is often called a rest and digest system. And so many people aren't able to access that. And of course, when things get worse, then it will flip into shutdown, numbing, dissociation, which actually is much more serious, but actually much harder to recognize. And I think we really need to train managers and people to recognize dissociative shutdown states, which are, and often that comes with PTSD symptoms, flashbacks, which might be a flashback of somebody dying, for example. But it might be also it might also be re-triggering traumas that they've experienced themselves in the past. So I think some basic education about these processes is very, very central. And one of the things I found working in the hospital setting, well, we did this intervention over about a year for a whole unit, was the terrible suffering that the nurses were experiencing as a result of not feeling they could do the job that they felt they ought to be able to do because the resources weren't there and the support wasn't there. And so it's something called it used to be called moral distress. I think it's called something else now. Moral damage, is it?
Moral injury.
Moral injury, yeah. Which actually is probably, in some of the research in the States, is the biggest predictor of staff turnover and burnout and those sorts of things. So if you feel you can't, so we always feel guilty when we do a job and it doesn't work out. If somebody dies at the end of it, there's always, I could have done this, I could have done that. That's human. But if genuinely your environment is one in which there isn't enough resources, there are not enough doctors and nurses, there's not enough, then that makes it doubly, trebly worse, I think, because you really genuinely feel like you're letting people down, and there might be a point to your worry about that. So I've moved slightly off from the trauma, but I think it's linked really. So I think all of these things, what they require, and what we did in this hospital that we worked in was coaching managers to try to facilitate a more caring, thoughtful, empathic environment where there was space for feelings and understanding. Coach the group in what a very typical Tavistock method of work discussion, where people had a chance to talk about some of the difficulties they were experiencing. And some of it was, I feel, underappreciated, and some of it was, this was a really, really difficult case. And then we gave them personal skills like mindfulness, and so actually just taking a breath can make quite a big difference. Feeling your feet on the ground, as you know, Jane, from your trauma yoga, can make a huge difference. Giving yourself a minute or two space in which to reground yourself. You put your own oxygen mask on, to use that metaphor, can actually, it feels like I haven't got time to do this, but actually it allows you to go forward and be much more effective in the long term, because you're rebalancing your nervous system and trying to give yourself something of what your body needs. If you're in a shutdown dissociative state, then you're out of your body in some ways, and we need to re-embody ourselves, find our breath again, find our presence, and then we've got a better chance of surviving this and coming through resiliently as opposed to traumatized.
And I'm sort of struck by what you're saying, Graham, that actually a lot of people might be blaming themselves for not coping. And I think there's quite a lot of shame around trauma, isn't there? Self-blame, or I can see my colleague doing this job is coping okay. Why aren't I? There must be something wrong with me. And you've talked about the importance of organisational dynamics and how organisations should be responsible for making sure that their practice is trauma informed. And it's a sort of a buzzword that's around a lot now. But what does that actually mean, Jo? What do you think workplaces can do to sort of make sure that the staff, if they're returning to work, if they've been furloughed or maybe not coming into work, or hospital settings or care home settings, social services, teachers, schools, what can they do to ensure that their staff are coming into an environment that is where well-being is really at the centre of what they're doing?
I think that's really an important question. And of course, one of the things that we have seen over this whole time is there has been a kind of flood of people wanting to help, particularly frontline staff. And whilst I think there's an enormous amount of altruism and reparative wishes in that, I think it's also been a bit problematic. And we saw something similar after Grenfell Fire, this difficulty of many people coming forward and wanting to offer things and help. And I think that organisationally, the NHS and the frontline staff have possibly struggled with that flood. And there is something, I think, linked to what, Graham, you were describing a moment ago, of kind of going back to really simple and yet vital things, making sure that people understand some of these basic ideas around fight, flight and freeze. So simple psychoeducation feels to me absolutely at the heart of this, because behind that, I think what we're saying to people is that this experience at the moment is an abnormal experience, but what they're feeling makes sense in those circumstances. So we've been talking a lot about trauma, but I don't think that means that we're talking about frontline staff having high rates of post-traumatic stress disorder. And often that's getting equated, and we lose then their resilience and their capacities and their potential for post-traumatic growth. So I think we have to be really careful about that, first of all. And then I think that the second thing is what, Graham, you described, I think, so well, of this kind of taking a pause, taking a moment, enabling people just to have a little bit of space that's built in to how the organisation functions. And I suspect each organisation finds its own way of doing that. And then I think the well-being part is providing different ways for people to be able to do it. And good well-being teams within NHS organisations find ways to be a part of the organisation, because of course that's what we also know in these kinds of events. People access help if it's from people they already know. They don't want strangers rushing in to debrief and to give them spaces. It doesn't work. And one of the interesting things is the number of helplines and things that have been set up that no one calls. But good well-being teams have been in there, and they have been just making sure that their visibility and their presence is seen. And I think that kind of thing will need to continue.
I know in my work, sorry Jo, I was just going to say, I mean, in terms of a practice, I think those are really good suggestions. I know that in my workplace, the management are really open to their staff members coming and talking about how they're feeling, and the question, how are you, genuinely asked, like, how are you? Yeah. And being welcoming to whatever the response is, and interested and concerned, and a good dose of compassion. It really can make a big difference, can't it?
Hugely. And I guess it leads to my final point on this, which I do want to say, is that for people who, as Graham was talking about a little while ago, do have significant trauma in their backgrounds, or who've had a lot of loss, maybe without time to fully grieve those losses, it may well be, and we know this from psychoanalytic theory, that this current situation will stir all of that up again. It will reignite it and make it feel as though those things are almost happening again. And for those members of frontline teams, there may be a need to seek more specific help, and being aware that might be the time to then get some help for those previous experiences that maybe haven't been worked through. So that can point people in the right direction for that's also really important.
Yeah, I really agree with that.
Yeah, so we're all psychotherapists, and we believe in how psychotherapy can be very helpful. As a yoga teacher as well, and mindfulness teacher, you're a mindfulness teacher as well, Graham. And you advocate all sorts of different treatments for trauma, Jo, don't you? As well as talking therapies. So for people who are listening to this and might be thinking, well, actually that might apply to me, this has been really triggering, what would you advise?
Well, I suppose the first thing is to actually let yourself really have that thought, and to explore it a bit, and maybe to explore it with people that you feel safe enough to let you explore it with them. That might be family members or friends, or it may be someone in the wellbeing team. There may be different options then that they could help you think about in terms of how to access help. It might be going to the GP would be a good way of doing that. I think we're going to be looking, and we've already begun this work in many different sites, at whether we set up specific pathways for people so that they can access this kind of help following the COVID-19 crisis. But I think there are a lot of those pathways are already there. So things like looking at GPs, there's often counsellors in primary care, and sometimes that's enough. There may also be charitable organisations. There's a lot of really good organisations that work well with bereavement. So I guess although I'm coming from a specialist trauma team, I'm certainly not saying that that's the answer for most people.
No.
they will find their different ways.
And for those people who are feeling quite stressed and maybe a bit overwhelmed, maybe other practices might be helpful in terms of perhaps movement, sport, singing. There are other things that one can do.
Yeah, all of those things give rise to a sense of belonging and being in a group, which actually also enhances those sort of good hormones that make you feel good.
Yeah.
I'd like to add one thing to that, though, which I think is really easily lost. And one of the things that really struck me when we were doing this work in the acute assessment unit over this year is how little people were able to give themselves a pat on the back for the extraordinary, absolutely extraordinary, heartwarming, amazing work that they were doing with some of their patients. Yeah. If you asked them to make a list of 10 bad things they've done, they would have a list of 50 within seconds. But think of 3 or 4 good things that you did that you're proud of. They couldn't think of them, and nor could hardly any of them remember a manager or a colleague telling them about the good qualities that they take to their work. And so just starting that process whereby in the feedback meetings and in the kind of handovers, or they made sure they gave space for thinking, well, that was really, the way you talk to that person, the way just having a little bit of positive feedback, it goes a long way. But that does require a more compassionate leadership. It does require managers who are able to slightly let go of the kind of top-down hierarchical management structures, as Jo was saying before, but able to open up to a more appreciative approach to their staff group, which really, really, really does go a long way. It's a bit like in trauma, we need to get back in touch with some good feelings in order to face the difficult feelings. And it's one of the mistakes that psychotherapy made for many, many, many years. And there's something similar in relation to this kind of ordinary work. In every workplace, you need to feel appreciated. If I'm honest, an institution that a few of us here know a little bit about, I can barely remember being told about doing things well. Actually, it's a rare experience, and we really all need that, not in a kind of superficial stroking way, but actually, especially when you're feeling under so much pressure and things can feel so difficult, we need to know that we're doing the best we can, and that we're doing a really good job under the circumstances.
It reminds me of that quote by Thich Nhat Hanh, no mud, no lotus. Yeah. And this time we've been talking a lot about, the very difficult problems that are arising in terms of trauma to frontline workers. But also this presents an opportunity for change as well in organisations, and maybe for people in people's lives as well. And if we can survive this, there is this opportunity, as you said, Jo, for post-traumatic growth as well. And maybe for things to really shift so that how we feel and well-being really, really is at the centre of all workplaces moving forwards. That's a big ambition, I'm sure, really to hope for. But maybe even if there's small changes that can happen, maybe we'll be a better society after all of this. Thank you both. Really, really enjoyed talking with you. Thanks very much for your time. Appreciate it.
It's been a pleasure. Thank you.
Thank you.